Patient's here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application for
your left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today we are shifting gears pretty significantly.
Yeah, we are.
We aren't just summarizing an article or, chatting about a trend. We are putting on a very specific hat.
The educator hat.
The hat of the nursing educator. We are stepping into the simulation lab, into the NCLEX prep session.
It's a necessary shift, I think. We're looking at a topic that is, it's a cornerstone of pediatric critical care and a huge favorite of exam writers.
Right.
But it's often misunderstood. People hear it and they just think, old history.
A rusty nail.
Rusty nails,
Right.
exactly.
Yeah.
We are analyzing tetanus, but we are not going to look at it that way. We are going to treat it for what it actually is. A neuroexotoxin emergency.
That distinction is so vital right out of the gate.
Yeah.
Because when you frame it as a neuroexotoxin event, the whole clinical picture, all your priorities, they just shift immediately.
They have to.
It stops being just a wound care issue,
Yeah.
and it becomes this neurological airway crisis. So we've got a massive stack of materials today. CDC epidemiology data, nursing standard of care protocols, pathophysiology textbooks, the whole 9 yards. And our goal is to synthesize all of this into that need to know versus nice to know framework.
Exactly. We are applying the 80-20 rule here. In clinical practice, and definitely on the board exams, about 20% of the concepts regarding tetanus will drive 80% of your decision-making.
And your patient's survival.
And your patient's survival, absolutely. Our job is to isolate that 20%, those high-yield patterns, and really drill down on the why. We're not just memorizing lists today. We need to understand the physiological mechanism so that when you're staring at a question or, a real patient, the answer is intuitive.
Okay, so let's start with that big picture, the master map.
Right.
If I'm a clinician or a student and I'm organizing my mental filing cabinet, where does tetanus live? Because it feels like a hybrid. It's not just one thing.
It is a hybrid, and that's a great way to put it. You need to file this under two distinct patterns, neuroinfectious and preventable disease.
Okay, break that down.
So, on the one hand, it shares the absolute urgency of something like a seizure disorder or bacterial meningitis because of the direct nervous system involvement. The crisis is neurological.
Right.
But on the other hand, it has the public health logic of vaccine schedules and prophylaxis. So you're thinking both like an ICU nurse and a public health nurse at the same time.
And looking at our notes here, our exam winner section, there is one specific decision point that seems to be the linchpin for almost every test question.
The wound management algorithm.
That's the one.
Without a single doubt. If you are taking the NCLEX or a pediatric board exam, I can almost guarantee you will see a scenario involving a wound and a vaccination history.
It's a classic.
It's a classic. And the test is this. Do you understand the immunology well enough to decide between just the vaccine plus immunoglobulin, or doing nothing at all? It's a logic puzzle with very high stakes.
We are absolutely going to break that algorithm down in excruciating detail later with some case studies because it is tricky. There are a few variables that can trip you up. But before we get there, let's talk about that first impression, the priority assessment cue. If I walk into a trauma bay or I'm triaging a patient, what is the immediate flag that screams tetanus?
Trismus. Lockjaw. But you need to look for the pattern, not just the one symptom.
Okay.
The pattern is descending muscle rigidity. It starts at the head and it moves down the body. So if you miss the tight jaw, which can be subtle at first, you might catch the stiff neck.
Okay, so head, then neck.
Right. And if you miss that, maybe you'll see the board-like abdomen. But here's the thing. By the time it hits the abdomen, you are already way behind the 8-ball. You've lost critical time.
And the can't-miss safety item, the thing that actually kills the patient if you don't anticipate it.
It's two things that are linked, airway protection and stimulus reduction. And this is really nuanced. It's not just about keeping the airway open in the usual sense.
What do you mean?
It's about realizing that the diaphragm and the vocal cords are muscles. And this is a disease of uncontrolled muscle spasm. So if the vocal cords spasm, what we call laryngospasm,
You have a total airway obstruction. Instantly.
instantly, it's like a door slamming shut, and you
Yeah.
can't just bag them through that.
And the stimulus reduction piece, how does that fit in?
That is the second half of the safety coin. These patients, their nervous systems are hyper-excitable, a loud noise from monitor alarm or a bright light flicking on. It isn't just annoying to them, it can physically trigger a generalized, life-threatening spasm or seizure.
So the environment itself.
The environment becomes a medical intervention. A dark, quiet room is as important as the IV drip.
Wow. Okay, there's one more concept on this master map that I have to admit I found really counterintuitive. We usually assume that if you survive a disease, you're immune to it, like chickenpox.
Right, tetanus breaks that rule. It completely
Having the disease does not confer immunity.
correct.
That just seems biologically unfair. Why does that happen?
It all comes down to the insane potency of the toxin. The toxin, it's called tetanospasmin, is so incredibly potent that the amount required to kill a human it's minuscule. We're talking nanograms. That lethal dose is actually too small to trigger a full-blown primary immune response. It doesn't stimulate the immune system enough to create memory B cells. So basically, the toxin can kill you without ever waking up the immune system's long-term memory.
So you can go through this horrific experience, survive weeks in the ICU, go home, step on another rusty nail a month later, and get tetanus all over again.
Precisely, which is why post-recovery vaccination is an absolutely non-negotiable nursing action. It's a critical teaching point for the family.
That sets the stage perfectly. Now, I want to go deep into the why. Let's move to the pathophysiology. The one-liner definition we have is that tetanus is a non-contagious, toxin-mediated disease of the CNS caused by Clostridium tetani.
And the key word there, for public health is non-contagious. This is the only vaccine-preventable disease that is infectious, but not contagious.
So you can't catch it from the patient in the next bed?
Never. It lives in the soil, in dust, in manure. It doesn't live in people.
Okay, let's talk about the agent itself, Clostridium tetani. The notes say it's an anaerobic gram-positive rod. Anaerobic is the key there, right? It hates oxygen.
It thrives in the absence of oxygen. It absolutely requires a low oxygen environment to grow. This is why the whole rusty nail thing is the classic trope, even if it's a bit of a simplification.
It's not about the rust.
It's not the rust at all. It's the fact that a nail creates a deep, narrow puncture wound. That hole closes up pretty quickly at the top, trapping the bacteria and spores in a low oxygen, warm, moist environment deep in the tissue.
You called it a luxury condo for the spores.
It's the perfect setup. The spores then germinate, they turn into active vegetative bacteria, and they start pumping out the toxin. And here's where we need to get really granular for the exam. The toxin, tetanospasmin, it doesn't just hang out in the wound.
Right.
It enters the motor neurons at the neuromuscular junction, and it travels retrograde.
Retrograde, so
Yes.
backwards, up the nerve.
Exactly. Normally, signals go from the brain down the nerve to the muscle, telling it to contract. This toxin hijacks the internal transport system of the axon, and it rides the nerve up from the muscle into the spinal cord and then up to the brainstem.
It's using the nervous system as its own private highway.
A one-way street in the wrong direction.
And once it gets to the central nervous system, what is the specific molecular violence it commits? We often hear the simple version, it blocks the brakes. But let's be specific for the clinicians listening.
Yeah, let's get into the synapse. To really understand the spasm, you have to look at the synaptic cleft. You have excitatory neurotransmitters like acetylcholine that say go, and you have inhibitory neurotransmitters that say stop.
Okay.
The main inhibitory ones in the spinal cord are GABA and glycine. Think of them as the brake fluid for your muscles.
So GABA is the chemical red light. It tells the muscle to relax.
Correct. So tetanospasmin gets into these special inhibitory interneurons, and it acts as a protease.
A protease, so it literally cuts proteins.
It's like a molecular pair of scissors. Specifically, it targets and cuts a protein called synaptobrevin, which is also known as VMP2. This little protein is absolutely essential for the vesicle, the little bubble containing GABA or glycine, to fuse with the cell membrane and release its contents.
So the neuron might be full of brake fluid. It might want to release GABA to tell the muscle to relax, but the mechanism to actually open the door and let it out is physically broken.
The door is welded shut. The toxin has cut the release mechanism, so the motor neurons are just getting constant, unopposed go signals without any stop signals. That leads to this high-frequency, uncontrolled firing.
And that is the spasm, the rigidity.
That is the rigor and the spasm. It's a failure of inhibition.
And this explains the unbound rule we see in all the treatment protocols. This is a critical point.
Yes, this is so important. Once the toxin gets inside that neuron and cleaves that synaptobrevin protein, the damage is done. You cannot glue that protein back together.
There's no reversing it at that point.
None. You literally have to wait for the nerve terminal to sprout a new ending and regenerate those proteins. And that takes weeks.
So when we give antitoxins like tetanus immune globulin, we are only mopping up the toxin that is still floating around in the blood or in the lymph, trying to prevent more nerves from being affected.
That's it.
We can't do anything about the damage that has already happened.
Exactly. We are trying to stop the recruitment of new nerves into the spastic state. We're containing the fire, not rebuilding the part of the house that's already burned down.
That makes the timeline of the clinical presentation makes so much more sense. Okay, let's transition to that. Section 3, clinical presentation and assessment. We mentioned the incubation period ranges from about 3 to 21 days with an average of 8. But there's a really important correlation between the injury site and that timeline.
Yeah, think about that retrograde transport we just discussed, that highway up the nerve.
Right.
If the injury's on your big toe, the toxin has to travel the entire length of the sciatic nerve to get to the spinal cord. That's a long commute.
A very long trip.
But if the injury is on the face or the neck,
it's a short commute, a quick trip to the brainstem.
And a shorter commute means a shorter incubation period. Clinically, a short incubation period, say under 7 days, is a massive red flag. It correlates directly with more severe disease and a much, much higher mortality rate. If symptoms show up in 3 days, you are in for a very, very difficult fight.
So let's walk through that descending pattern of symptoms. Why does it almost always start with trismus, with the lockjaw?
It's a combination of a couple of things. One is the shorter neural pathways in the head and neck, especially for cranial nerves. But it's also the high density of motor units in the masseter muscles, the big jaw muscles. They are incredibly strong and they're very sensitive to this loss of inhibition. So trismus is often the very first sign you'll see.
Okay, so jaw first, and then it moves down. Neck stiffness, dysphagia.
And dysphagia, the difficulty swallowing, is so critical. It's not just uncomfortable. It leads to drooling, pooling of secretions, and a huge aspiration risk.
Right.
Then it hits the trunk. This is where you see that classic board-like rigidity of the abdomen. The rectus abdominis muscles are contracted as hard as they can possibly be. It feels like a sheet of wood on palpation.
And now for the red flags that we absolutely need to have memorized for an exam. We have laryngospasm, rhesus sardonicus, and opisthotonus. Let's start with rhesus sardonicus.
Rhesus sardonicus is Latin for sardonic smile or sardonic grin. It's really eerie to see. The facial muscles all contract at once, pulling the eyebrows up and the corners of the mouth out and down. It looks like this fixed, creepy grin on the patient's face, even while they're in agony. It's pathognomonic. It's diagnostic.
And opisthotonus. I've seen pictures of this, and it's horrifying.
It is. This is a state of global extension. What happens is the extensor muscles in the back are just anatomically stronger than the flexor muscles in the abdomen. So when everything contracts at once, the back wins.
The stronger muscles overpower the weaker ones.
Exactly. The patient arches backwards so severely that they might be resting only on the back of their head and their heels, with their entire body bridged up off the bed. In neonates or small children, this force can be strong enough to cause compression fractures of the vertebrae.
Just from their own muscles.
Just from the force of their own muscle spasms.
That leads us to the other critical piece, the autonomic dysfunction. It's not just the skeletal muscles. The fight or flight system is completely broken too.
Right. The toxin also affects the autonomic nervous system. The sympathetic nervous system just goes haywire. You get these massive, unpredictable surges of catecholamines, adrenaline, noradrenaline.
So what does that look like at the bedside?
You'll see wild swings, tachycardia, so a really fast heart rate, labile hypertension, where the blood pressure is spiking up to 220 over 150 1 minute and then dropping way down the next, profuse sweating, drenching the bed, and high fevers. This autonomic storm is incredibly dangerous and can cause a cardiac arrest even if the airway is perfectly managed.
Okay, we have the picture of the critically ill patient. It's grim. Now, let's go upstream to the decision-making that prevents this from ever happening. The exam writer's favorite, the wound prophylaxis algorithm.
Oh, this is it.
This is the part that trips up even experienced nurses because of all the variables.
It's a matrix. You just have to think of it as a 2x2 table. You have 2 axes. The wound condition, which is either clean minor or all other wounds dirty, puncture, burn, crush.
Okay, clean versus dirty.
And the second axis is the vaccination history. Is it unknown or incomplete, meaning less than 3 doses? Or is it complete, meaning 3 or more documented doses?
And where you land on that grid tells you what to do.
Precisely.
Okay, let's role play this with specific case studies to really lock in the logic.
Let's do it. Best way to learn.
Okay, case study 1. You have a 12-year-old boy, let's call him Leo. He was helping his dad in the garage and sliced his hand on a clean new box cutter. It's a superficial cut. You wash it out, it looks very clean. His mom has his records. He had all his baby shots and his booster at age 4, but he hasn't had his 11-year-old Tdap yet. What do we do?
Okay, perfect. Let's use a matrix. Variable 1, the wound is clean and minor. Variable 2, his vaccine history is 3+ doses. He completed that primary series as a baby.
Right.
For clean wounds in a fully vaccinated person, the rule is the 10-year rule. We need to know when his last dose was.
It was at age 4. He's 12 now.
So that was 8 years ago. Is it 8 less than 10? Yes, it is.
Yeah. We do nothing.
Action. Clean the wound thoroughly. No vaccine needed today. No TIG needed. He's still considered protected for a low inoculum clean wound. He's within that safety window.
Okay, that makes sense. Case study 2. Let's change the variables. Same kid, Leo, 12 years old. But this time, he wasn't in the garage. He was out playing in a muddy field, and he stepped on an old, rusty piece of farm equipment. It's a deep puncture wound, contaminated with soil. Same vaccine history. Last shot at age 4.
Okay, everything changes now. Variable 1. This is dirty wound. It's a contaminated or all other wound. Variable 2. History is still 3+ doses.
So what's the rule now?
Because the wound is dirty, the potential antigenic load, the amount of bacteria and potential toxin is much, much higher. We can't rely on that 10-year window anymore. For dirty wounds, we switch to the 5-year rule.
Ah, okay, the 5-year rule.
It has been 8 years since his last shot. That is more than 5 years ago.
So he needs a booster.
Action. Give the vaccine. In this case, Tdap. We want to spike his antibody titers right now to handle that increased threat.
But do we give the immunoglobulin? Do we give TIG?
No. And this is a key distinction. His body still has memory from those previous vaccines. He has memory B cells. The booster shot will wake up that memory very quickly within a few days, and he'll mount a strong antibody response. The risk of fulminant tetanus is low because he has a primed immune system. TIG is not needed.
Okay, now for the scenario that gives everyone anxiety. Case study 3. A 6-year-old girl, Maya. Her family has just immigrated, or perhaps they're vaccine hesitant. The bottom line is, she has no vaccination record. Her history is unknown. She falls off her bike into gravel and has a deep, dirty abrasion that's contaminated with road debris and soil.
This is the danger zone. This is the one you cannot miss.
Right.
Variable 1, dirty wound, high risk. Variable 2, unknown or incomplete history. We have to assume she has 0 protection.
So we have a high-risk entry and basically no defense system.
Correct. A vaccine takes weeks to build a primary immune response. We do not have weeks. She could be symptomatic in a few days.
So what's the action?
Action. You must give both the vaccine, in this case DTaP since she's under 7, to start that long-term training, and you give TIG, the tetanus immune globulin.
Okay, explain the role of TIG here again. I love your analogy for this.
Think of the vaccine as a boot camp for the immune system. It takes time to recruit and train soldiers, right? To build an army.
Weeks.
TIG is like hiring a battalion of elite, pre-trained mercenaries today. It provides immediate passive immunity. These are borrowed antibodies harvested from donors that will go in and start hunting down any circulating toxin right now, while the vaccine is busy training the body's own cells for the future war.
That mercenaries versus boot camp analogy is the key to remembering it. You only call in the mercenaries when you have a dirty war and no standing army of your own.
Precisely. And just to round this out, there is one major special population exception we have to mention.
Immunocompromised patients.
Right. If Maya, in that last scenario, had HIV or was on high-dose steroids or chemotherapy,
The rules change.
the rules change completely. Even if she had a documented history of vaccination, we cannot trust that her compromised immune system maintained that memory or could mount a response. So the rule is, if an immunocompromised patient has a dirty, tetanus-prone wound, they get TIG regardless of their vaccination history. We just don't take the gamble.
That covers the algorithm beautifully. Listeners, rewind that section a few times if you need to. That logic is, I'm not kidding, probably 80% of your exam questions on this topic.
Absolutely.
Now let's move to section 5, medical management. The prevention failed. We're in the PICU with a child with active tetanus.
We are in full crisis management mode now. The priority immediately shifts to the stop the crash list.
And item number 1 on that list is always airway. But you mentioned earlier this isn't a standard intubation.
No, it's a difficult airway by definition. Think about it. If the patient has severe trismus, you can't open their mouth to get the laryngoscope in.
You can't visualize the cords?
And if they're having a laryngospasm, the vocal cords are clamped shut. You often cannot physically pass an endotracheal tube. Trying to do so can make the spasm worse.
So what's the solution?
The clinical pearl here for your exams and practice. These patients often require an early tracheostomy.
So you bypass the problem area entirely.
You bypass the cords, it securely establishes the airway, and it also allows for long-term ventilation, which they are almost certainly going to need for weeks while the nerve endings regenerate.
Okay, airway is secure. Next is neutralizing the toxin. We're giving TIG again, but this time it's therapeutic, not prophylactic.
Yes, much higher doses than the prophylactic shot. We're talking 500 to maybe 3,000 units, depending on the severity. And here's a little procedural note you might see. We often infiltrate part of that TIG dose directly into the tissue around the debrided wound.
Like you're injecting a perimeter defense.
That's a perfect way to put it. We're trying to neutralize any toxin being produced right there at the source before it can even enter the bloodstream and travel to the nerves.
That's smart. Then we have wound care and antibiotics.
Debridement is absolutely crucial. You have to surgically go in and remove all the dead necrotic tissue. Remember, the bacteria is anaerobic. Dead tissue has no blood flow, which means no oxygen. If you leave it there, it's a toxin factory.
You have to shut down that factory.
You have to clean it out. Then we use antibiotics. Typically, metronidazole is favored now over penicillin G to kill the live vegetative bacteria that are producing the toxin.
Now let's talk about spasm control. This is where the pharmacology gets really heavy. We're not just giving a little Tylenol here.
No, not at all. The first line is high-dose benzodiazepines, the V-diazepam, or a midazolam infusion. These are GABA agonists. They work on the GABA receptors to try to artificially stimulate the inhibitory system that the toxin has disabled.
But often that's not enough, is it?
Often it's not. The next step we might add is magnesium sulfate.
Magnesium, that's usually an OB drug for preeclampsia, right?
It is, but it works for the same reason. Magnesium acts as a calcium antagonist at the presynaptic nerve terminal. It blocks the release of excitatory neurotransmitters like acetylcholine, and it also relaxes smooth muscle. It helps with both the skeletal muscle spasms and with that dangerous autonomic instability, the blood pressure spikes.
And if that still doesn't work, if the spasms are breaking through the benzos and the magnesium,
Then the final step is a full neuromuscular blockade. We use drugs like vecuronium or rocuronium to induce a chemical paralysis. We stop the muscles from moving entirely.
so the patient is completely paralyzed.
Completely. This allows the ventilator to do all the work of breathing. It stops the patient from breaking their own bones, and it dramatically lowers that insane metabolic demand.
This leads perfectly into the nursing environment.
Yeah.
If I'm the nurse assigned to this child, my actual behavior in the room is a critical intervention.
Yes. This is the dark room protocol. You will see this on exams. The goal is to prevent seizures and prevent spasms, and the action is complete stimulus reduction.
So what does that look like in practice?
You keep the room as dark as possible. You minimize noise. You silence alarms when you're in the room or set them to a low volume. You avoid bumping the bed. And critically, you cluster your care.
Explain what clustering care means in this context.
It means you don't go in at 8 o'clock to check the blood pressure, then go back in at 8:15 to give a med, then back again at 8:30 to suction.
Because every interaction is a potential trigger.
Every time you touch that patient, you risk triggering a tetanic spasm. So you plan ahead, you go in once, maybe you give some extra sedation first, then you do everything you need to do all at once. You suction, you turn them, you give meds, you do your full assessment, you check your lines, and then you get out and you let them rest undisturbed for as long as possible. You coordinate with respiratory therapy, with physical therapy, so you're all touching the patient at the same time.
It's not just minimally invasive.
It's a survival interaction. That's what it is.
Let's broaden our scope now to the pediatric focus. This is so important. Section 6. Age-specific presentation and developmental impact. The sources all highlight neonatal tetanus specifically.
Yeah, this is a global health tragedy. It's sometimes called the 7-day death. It occurs almost exclusively in infants born to unvaccinated mothers.
Because the mother has no antibodies to pass through the placenta.
Exactly. The baby is born with zero passive immunity, zero protection.
And the source of the infection isn't a puncture wound.
No, it's the umbilical stump. In many low-resource settings or due to certain cultural practices, the umbilical cord might be cut with an unsterile instrument bamboo, a kitchen knife, Or the stump might be dressed with things like mud, ash, or even cow dung. These materials are just loaded with Clostridium tetani spores.
And the incubation period is very short, only 4 to 14 days.
Right. So the baby is born, seems fine, starts nursing normally for a few days, and then they stop. They stop feeding because of Lockjaw, the Trismus. Then comes the rigidity, the characteristic spasms. The mortality rate without modern intensive care is nearly 100%. It's devastating.
Okay, let's talk about the survivors. The toddlers or older kids who get tetanus and make it through the ICU. How does this disease and the treatment impact their long-term development?
The physical impact can be severe and lasting. We talked about fractures. Imagine a 2-year-old who has just mastered walking. They suffer vertebral compression fractures from the spasms. They're now immobilized in a back brace or even traction for months. That is a massive regression in their gross motor milestones. They may have to learn to walk all over again.
And what about the nutritional aspect?
The metabolic rate of a tetanus patient is sky high. That constant muscle activity burns calories like an Olympic sprinter, 247. But at the same time, they can't swallow because of the dysphagia, so you have this huge caloric need and no way to take in nutrition orally.
They're in a catabolic state.
A profoundly catabolic state. Severe weight loss and malnutrition are major risks, which in a young child directly affects brain development and overall physical growth.
And then there's the psychological trauma of the ICU itself.
Right. Prolonged hospitalization is the key phrase here. We are talking 3, 4, maybe 5 weeks in a pediatric ICU, often paralyzed and sedated.
What does that do to a developing child?
Well, it depends on their age. For an infant or toddler, it's a huge disruption to attachment and bonding. It can cause severe separation anxiety. They can lose newly acquired skills like toilet training or sleeping through the night.
And for an older child?
For a school-age child, it's terrifying. It's fear of bodily harm, pain, loss of control. They miss their friends, their school, their routine. For an adolescent, think about body image. Waking up with a tracheostomy scar on your neck, being weak, deconditioned, having lost all your autonomy, it can be absolutely devastating to their sense of self.
So as the nursing educator in this scenario, what is our key intervention to protect their development?
You have to advocate fiercely for family presence. Even within that darkroom protocol, this is a critical nuance. The parent is the anchor in that storm. They shouldn't be overstimulating the child, of course, but they can sit quietly by the bed, maybe hold a hand if the child can tolerate it. That familiar, tactile reassurance can reduce anxiety, which can actually lower the risk of spasms.
That's a great point. So you reduce the bad stimuli, like lights and alarms, but you try to maintain the good stimuli, which is the parental presence.
That's a beautiful way to put it. Safe care does not mean isolated care.
Okay, let's talk prevention. Section 7, the vaccine schedule. We have this alphabet soup of vaccines. DTaP, Tdap, DDDDT. It can be confusing.
It's a code, but it's a simple one once you learn it. The uppercase letters, the big D and the big P, denote the full-strength dose of the diphtheria and pertussis components. The lowercase letters, little d and little p, mean a reduced-strength dose.
Okay, so DTaP.
Big D, big P, full-strength diphtheria and pertussis. This is for the little, naive immune systems of children under 7 years old.
And Tdap.
Little d, little p, reduced strength. This is the booster for older children, so 11 and up, and for adults.
And why do we reduce the dose for older kids and adults?
Primarily to reduce local reactions. As our immune systems mature, that full-strength big D can cause a lot of sore, swollen, painful arms. The reduced dose is just as effective as a booster, but much better tolerated.
And then there's TD.
TD is just tetanus and reduced diphtheria, no pertussis component. This is often used for the every 10-year adult boosters if Tdap isn't indicated or available.
So let's run through the schedule quickly.
Okay, the primary series for infants is given at 2 months, 4 months, and 6 months.
Then the boosters.
The first booster is between 15 and 18 months. The second booster is between 4 and 6 years old. That's the kindergarten shot.
And after that?
The adolescent booster is at 11 to 12 years old, and that should be a Tdap to get that pertussis protection back in there. And then for adults, it's a booster every 10 years.
There is one absolutely crucial core add-in here for pregnancy that connects right back to what we said about neonatal tetanus.
Yes, this is part of the cocooning strategy. The current recommendation is to give a dose of Tdap during every single pregnancy.
Every pregnancy. Even if the mom had a Tdap just 2 years ago with her last baby.
Yes. every single time. Because we are not vaccinating the mom for her own sake in that moment, we are timing the vaccine ideally between 27 and 36 weeks gestation so that her antibody levels for both tetanus and pertussis will peak and then cross the placenta right before birth.
So we're passively vaccinating the fetus.
You're giving the baby a gift of antibodies to protect them during those first critical 2 months of life before they're old enough to get their own first shots.
That is a definite must-know for any exam, every pregnancy. Okay, last section, Section 8, complications and nice-to-know facts. What other complications can kill these patients in the ICU?
We've mentioned laryngospasm and fractures, but you can't forget about blood clots. Pulmonary embolism is a real risk. These patients are completely immobile for weeks. DVT prophylaxis is standard care.
And pneumonia.
And aspiration pneumonia is huge. Some studies show it's found in 50 to 70% of autopsy tetanus cases. That combination of dysphagia, pooled secretions, and heavy sedation makes the lungs a prime target for a secondary bacterial infection.
Okay, now for the nice-to-know context. Give me some history or science trivia that will help cement this in our brains.
Okay, let's talk about the resilience of the spores. We mentioned boiling earlier.
Right.
If you boil water to 100 degrees Celsius or 212 Fahrenheit, and you put Clostridium tetani spores in it, they survive. They can survive boiling for 20 minutes, 30 minutes, or even longer.
So home sterilization of, say, a needle or an instrument is basically impossible for this.
Correct. You need an autoclave. You need both heat and pressure. You need 121 degrees Celsius, about 250 Fahrenheit, under pressure for at least 15 minutes to reliably kill the spores. This is why field surgery with improvised tools historically carried such an incredibly high risk of tetanus.
And speaking of history, WWI.
In the Civil War and early World War I, tetanus, or lockjaw, was a leading killer of wounded soldiers. You had these massive shrapnel wounds contaminated with soil from the trenches. It was a perfect storm. The widespread introduction and use of the tetanus toxoid vaccine in WWII caused a massive dramatic drop in cases. It was one of the first major victories of military preventive medicine.
One final epidemiological paradox before we close. We started with this, but I really want to drive this point home.
Let's do it. It's about tetanus and herd immunity.
Right.
Herd immunity works beautifully for contagious diseases like measles. If 95% of the herd is immune, the virus can't find a susceptible host to jump to, so the 5% who are immune are passively protected by the vaccinated people around them.
But this logic completely fails for tetanus.
Completely, because tetanus doesn't jump from person to person.
It's in the dirt.
It's in the dirt. It does not care if your entire city is vaccinated. You could be the only unvaccinated person in a 100% vaccinated community, step on a nail in your own backyard, and die from tetanus. Protection is strictly 100% individual. You can't borrow it from your neighbor.
That is such a powerful closing thought. It puts the responsibility squarely on the provider to check that history, to ask the right questions every single time.
Every wound, every time, no exceptions.
Okay, let's recap the core 80-20. The absolute must-knows. Number 1.
The MAP. It's a neurotoxin emergency. Your first thoughts are airway and seizures.
Number 2. The patho.
It travels retrograde up the nerve. It cleaves the VMP2 protein, which blocks GABA and glycine. It cuts the brakes, and that causes the rigidity.
3. The algorithm. This is the big one.
Clean wound, you use the 10-year rule. Dirty wound, you use the 5-year rule.
And the danger zone.
Dirty wound plus an unknown or incomplete history. They get both the vaccine and the TIG. You call in the mercenaries.
4. The care in the ICU.
Dark room, clustered care, early airway security, think track, and high-dose benzodiazepine.
And the final, unbreakable rule.
Recovery does not equal immunity. You have to vaccinate them before they go home.
That is the blueprint.
That's it.
To all the nursing students sweating over the NCLEX and all the clinicians out there keeping the ER and the ICU safe, you are now armed with a deep dive on tetanus. Go be the expert in the room.
Stay curious and check those vaccination dates.
We'll see you on the next deep dive.